I am a woman, and I'm going to tell you we're much more complicated, okay? So when a guy goes to the mall to go to the Gap to buy a pair of jeans, they walk in the entrance, they walk in the store, they get their jeans, and they walk out. When a woman goes to the store, it's like hell, right? Up and down and all around. And the point of this is, and I want you to understand, is that especially with heart disease, we don't really understand how women and heart disease, how their roles are kind of combined. The major cardiovascular studies that come out, even still to date, the majority of the time, women are only about 20 to 25% of the study population. So even when these big major trials come out, we're really still not sure if women, the results of the studies are about women as well, okay? So the American Heart Association continues to really delve a lot of money into the women's cardiovascular research sector. So looking at this, on the y-axis we have deaths in thousands, so the very top is 520,000, at the very bottom is 400,000. And then we have the years across the x-axis from 1980 all the way to 2004. And we'll see right around 1980, almost 1985, the mortality for cardiovascular disease plummets for males, and it actually has increased in women since that time. Now, around the year 2000, they both started to kind of dive off, but if you see all the way over on the far side of the y-axis, we still have many more females dying of cardiovascular disease than men, okay? And what we'll get into later on in the presentation is it really has to do with the fact that they're not being diagnosed, all right? It has nothing to do with the fact that we can't treat them. It has everything to do with the fact that they're not being diagnosed early. All right, so heart disease is the #1 killer of women. There was a big study, and again, we're going to get into that later, and women's perception on whether that's true or not. Breast cancer will kill 1 in 30 women. Heart disease will kill 1 in 3. 1 woman dies every minute of heart disease in the United States. And again, just like we saw, more women are dying from heart disease than men. Interestingly enough, it also affects different racial groups. So if we look here, we see that there's a large amount of females that are dying of heart disease. However, we see that there's a discrepancy amongst white females and black females, okay? Some interesting statistics. Black females that are over 20 years old, 49% of black females over the age of 20 years old have heart disease, almost 50%, okay? And 40% of black females as a whole have hypertension. So what I see in my practice, and I get this a lot, I'll take females as a whole, but I'm going to use black females because it really is more outstanding. They will come to me for really primary care, because I do primary care as well. And I'll have a black female that's maybe 35 years old. And I see her, and her blood pressure is 150/95. And I tell her, you have high blood pressure. Oh, I've had it for 5 years. They told me not to worry about it. Okay, you have to treat these people, all right? If they're this big, diet and exercise is not going to do anything. Okay, you have to treat them. Do not undertreat these patients. 50% of them have heart disease, so you have to treat them. 90% of women have 1 or more risk factor for cardiovascular disease. Fewer women than men will survive their first heart attack. That's multifactorial in the sense of they get help later in terms of calling 911 or going to the hospital or going to their doctor because they think their symptoms are something else. And unfortunately, they receive worse care in the emergency department, okay? Because no offense to emergency department physicians, but there's still a big discrepancy on the 40-year-old female walking in with chest pain and the 40-year-old male walking in with chest pain, okay? They're not getting treated as quickly, and they die. Hispanic women are likely to develop heart disease 10 times earlier than Caucasian women. That really has to do with the elevated risk of diabetes and hypertension in these patient populations. Women are more likely to wait longer before presenting for medical attention. That has to do with a grassroots campaign, and that really kind of boils down to the primary care physicians having, a 2-minute discussion with females. If you have chest pain, if you're having unrelenting nausea, if your arm doesn't feel right, you need to call 911, okay? Also, women are referred less often for appropriate testing or treatment. This is not just by PCPs, this is also by cardiologists. Oh, your chest pain's just anxiety, don't worry about it. It's no big deal. And so they don't do the stress test, okay? I'm going to tell you also, I see this a lot with palpitations. I had a woman come to me, and she had palpitations for years, since she was in her 40s, and she had it since her first pregnancy. And after her second pregnancy, they got worse, and they got worse. And her primary care physician says, oh, now I'm in South Florida, so we call it Hispanic female hysteria. It's just palpitations, and everyone says that. It's just anxiety. So I said, I don't know, something's not right. I put a telemetry monitor on her for 3 weeks, and she was in SVT with a heart rate of 190. And this has been going on since she was in her 20s. Just order the telemetry monitor or the Holter monitor. It's not a big deal, okay? I also had a young girl who I heard her murmur on. This is a great story because all of us have like the 1 or 2 cases that you really feel like you like really made a difference and you saved someone's life. She was 32. She came to me for a physical for primary care. And I listened to her and I say, Alex, you've got a murmur. And she said, but and I'm thinking like, when I tell someone they've got a murmur, it's a real murmur. It's not like a trace MR murmur. It's like real, right? And she says, oh, I've had it my whole life. I've had it since I was a baby. We don't have to do anything. I said, let's do the echo. She's like, no, please, it's not even your deductible. It's like a $30 copay. Just let me do your echo. Fine, we can do your echo. A 2-centimeter ASD. Her right ventricle was bigger than her left ventricle. Had to have like almost emergent surgery because she almost had irreversible pulmonary hypertension at 32 years old. If you don't know, please get a consult. And if the consult's not doing what you think should be done, just order the echo. Okay? This girl comes back with like balloons and wine and like engraved things. And she says, I was able to run 2 miles every day, or 3 miles every day my entire life. And about last year, I gained 10 pounds, and I thought, oh, I can't run the 3 miles anymore because I gained some weight. And I said, that was the hole. That's why you couldn't run your 3 miles anymore. So this girl was still running 2 miles a day with a 2-centimeter ASD with massive shunting to her right ventricle. We close it. She calls me, because I'm bad, I give patients my cell phone number. She calls me and she says, Doc, I literally have been running for an hour and a half, and I can't stop because I feel so good. Women blame their symptoms on a lot of other things. And she was blaming it on a 10-pound weight gain. And mind you, she was still only like 135 pounds. Okay? So we have to almost pull these symptoms out of these women because they're not just going to come and tell you. All right, so women, myth number 2. Women do not need to worry about heart disease prior to menopause. So if we look, there's a new kind of shift in the paradigm, okay? Previously, we thought really up until the age of around 50-ish, around menopause, the average age is 51 in the United States, that really there's a very low risk of cardiovascular disease in women. And kind of when you hit menopause, it's like, as my old professor would say, feces would hit the fan and everyone started having heart attacks after that age, okay? What we're learning now is it's a different paradigm, okay? It is not like you hit menopause and all of a sudden you start getting heart disease. We have learned that there is a very steady increase in heart disease in women throughout their lives at about 8% per year every single year. There's a few studies that looked at hormone replacement and the role of estrogen in preventing heart disease in women. And I'm not going to get too far into the studies because when we talk about actual hormone replacement, the studies, it's more important to talk about those studies then. But the first study, which is the heart and estrogen progesterone replacement study, this was done in the late 90s. And it was a study that was followed up initially over 4 years. What the study showed is that although estrogen decreased the LDL by 11% and increased the HDL by 10%, the hormone replacement therapy did not prevent future cardiovascular mortality or events. Now, this was very different than observational studies, which showed a much different picture. So when we went back and we looked at the timeline of this particular study, they saw that in the first year to year and a half, there was an elevated cardiovascular death. And that death kind of tapered off to where the last approximately 3 to 4 years of the study, there was no difference in cardiovascular mortality. Not a benefit, there was no difference. So then we said, well, man, maybe these observational studies, they were so much longer of a study that maybe these women were having a decrease in cardiovascular mortality because they'd been on the estrogen for so long. So then in 2002, they did a follow-up, and this was about 7 years out. And what that follow-up showed is that the estrogen replacement did not improve cardiovascular mortality. And on the other hand, it actually increased the risk of deep venous thromboses. So the recommendations were from those 2 studies that the estrogen replacement is not improving cardiovascular mortality. The Women's Health Initiative was a much larger study, and we're going to get into that in a second. Okay, so again, prior to menopause, there may be some slight role of estrogen. However, what we're beginning to think now is it doesn't have to do with women at age 50 having an increased risk of heart disease. What we think it is it's more of an acceleration of heart disease in men. So we're focusing on the fact that the women are having heart disease at 50, and we're not focusing on the fact that the men are having it at 40, okay? So what is it about men that they're having an acceleration of heart disease? There's a hypothesis about telomere length. So when we're all born, all of our telomeres are about the same size, and those are really what is a biological marker at a cellular level for aging. And what we know is that men, from a one-to-one standpoint, after birth, their telomeres shorten much quicker than women, okay? And that cellular aging has to do with every cell in the body, including the cardiovascular system. So the longer telomeres in women, there's a hypothesis out that maybe women have less heart disease earlier in life because of that telomere length. There's also some research being done in regards to estrogen and telomere length, and that the estrogen's effect on the telomerase activity might be one of the reasons estrogen can potentially play a role in cardiovascular disease. There's a huge association between smoking and menopause. Women who smoke have, on average, approach menopause 2 years earlier than women who do not smoke. And white females with certain genetic issues, I guess is the right word, they can actually have, and if they smoke, they can have menopause up to 8 years prior than the normal population. Okay, so when we're looking at heart disease and menopause and early menopause, a lot of this has to do directly with the smoking, and it has really nothing to do with the menopause, okay? 80% of women under the age of 40 years old who had a heart attack were smokers, 80%. Okay, so if you see someone that coming into the hospital and they're 39 years old and they're a smoker and they're complaining of chest pain, it's probably real, okay? Other things that decrease the age of menopause: high cholesterol, high blood pressure. So if you have a patient that's a hypercholesteremic, hypertensive smoker, they will hit menopause sooner than other women. That's going to increase their cardiovascular risk just because of the sheer risk factors. That has nothing to do with the menopause. It has everything to do with the risk factors. Okay, so what we're realizing, again, this whole paradigm has started to shift. Okay, it's not the menopause that's causing the heart disease. It's the risk factors that occur the longer that you live. A few statistics I thought were interesting, actually. If a woman has menopause prior to 35 years old, they have a 2 to 3-fold increased risk of cardiovascular disease. And menopause between the ages of 35 and 40, there's a 2 times increased risk of cardiovascular disease in those patients. So again, this all has to do with the risk factors. And the more risk factors you have, the more likelihood you are to have an early menopause. Okay, so myth number 3, hormone replacement therapy is dangerous and should never be taken. All right, so what are some good things about hormone replacement therapy? Obviously, first and foremost is the relief of the postmenopausal symptoms. I can't comment on it, but I mean, I've seen it and it looks pretty terrible. Reduction in osteoporosis and fractures, and improvements in lipid profile. So the LDL will go down and the HDL will go up. However, there's an increased risk of breast cancer, endometrial cancer, and a markedly increased risk of blood clots. So the Women's Health Initiative study is a study that all of you should be somewhat familiar with if you're taking care of females as a whole over the age of 50, okay? This study was huge. There's 2 arms. There's an estrogen-only arm and an estrogen and progesterone arm, okay? The arm with the estrogen and progesterone had over 16,000 patients, aged from 50 to 79 years old that had an intact uterus. These patients were also placed on progesterone to help ameliorate the endometrial cancer. The study was stopped at a mean of 5.6 years, which was early. It was supposed to go to about 8 years. And what they saw was an increased risk of heart disease, okay, actually being on the hormones, of 29% increase, an increased stroke risk of 41%, a markedly increased risk of blood clots, an increased risk of blood cancer, and the 2 that were reduced were colon cancer and hip fractures, okay? So based upon this arm of the study, There was a conclusion made that hormone replacement therapy should not be used to prevent disease. Okay, we're not talking about symptoms, we're talking about preventing cardiovascular disease. In the second arm of the study, there was about 11,000 patients, both, again, postmenopausal, aged, again, 50 to 79. These patients had a previous hysterectomy, so they were on estrogen only. This study was also stopped early at about 6.8 years. And in the estrogen-only arm, they noticed a 9% reduction in heart disease, but a 39% increased risk of stroke, a 33% increased risk of blood clots, no change in cancer in these patients, and a 39% reduction in hip fracture. Now, the problem with this study is you see that in both arms, there's 50 to 79 years. The average age is 62 in this study. And when do most women hit menopause? 51. Okay, so it was a major flaw of this study because they're making recommendations based upon someone that's more than 10 years out from their menopause date. So when we looked at it from an age group standpoint, those women who were within the 10-year range of being within menopause had a reduction of both heart disease and stroke. 37% in heart disease and 11% reduction in stroke. The older you get, the worse you were in terms of having any benefits, and actually it was actually detrimental to be put on hormone replacement therapy. So the recommendation is the following. If you're using hormone replacement therapy because someone is having horrendous symptoms and you need to treat their symptoms, you have to have a discussion with your patients, and they need to understand that if they're more than 10 years out from their menopause date and you're treating their symptoms, they do have an increased risk of heart disease and stroke. There is some benefit to patients if they're having symptoms still that are within the 10-year mark of placing those patients on hormone replacement therapy. Even more so in surgical menopause patients where they're 35, 40 years old and they have surgical menopause, those patients can be placed on hormone replacement therapy short term. Okay, so again, take home point. Estrogen therapy is reasonable for the relief of perimenopausal symptoms if it is started early and tapered after a few years, and we should never be giving it to reduce cardiovascular risk. What do we want to do to reduce cardiovascular risk? Same thing as everyone else, risk factor stratification. Okay, so no smoking, watch the blood pressure, watch the cholesterol, make sure they're not diabetic. All right, myth number 4, vitamin supplementation prevents heart disease. These are my favorites because I have people that come in with just these bottles and bottles and bottles of vitamins. It kills me. So there's 2 studies, one on vitamin E and one on vitamin B. Vitamin E came out in JAMA in 2005, and the vitamin B study came out in JAMA in 2008. This is another very large study, approximately 40,000 patients, otherwise healthy women greater than age 45. Okay, so these patients did not have cardiovascular disease. They were healthy 45 years and above patients. They were randomized to a placebo or vitamin E 600 international units daily, also with a baby aspirin every other day. We realized that there was no statistical significance in the cardiovascular mortality in the patients who were taking vitamin E. There was, however, interestingly enough, a subset of patients in the women who were greater than 65 years old. They had a 24% decrease in secondary endpoint of CV death, and they had a 26% decrease in major cardiovascular events. So when physicians asked the researchers in the study, why are we not addressing this? I mean, there was a statistically significant difference in those women who were greater than 65 years old. And they said, yes, our study said that. However, other studies that have been done did not show that. So we still kind of don't know what to do in regards to this. The nice thing about vitamin E, you're probably not going to do any harm. So if you are going to recommend vitamin E to a patient, it really should be that patient that's older than 65 years old. The only adverse effect with being on the vitamin E is there was a very small increase of mild epistaxis because of the platelet inhibition that can happen when you take vitamin E. Other than that, there was no statistically significant adverse effects between placebo and vitamin E. So as a whole, it's not recommended. If you are going to recommend it, it really should be your female patients who are otherwise healthy and greater than 65 years old. The second study had to do with B vitamins. And the reason this study was done is there was another study done, basically the same thing, but it was mostly men. So we said, okay, well, we know what happens in men, but maybe women are different, and maybe women will benefit from having folic acid and other B vitamins. So this was a study of about 5,000 patients. These women actually did already have cardiovascular disease, or they had greater than 3 risk factors. So these were not otherwise healthy patients. We were looking at patients who actually had cardiovascular disease or major risk factors. Once again, we noticed there was no statistically significant difference. What was interesting is the homocysteine levels in the patients that were treated with the B vitamins did decrease by almost 20%. And we know homocysteine is an inflammatory marker, and it sets off an inflammatory cascade and can have issues with thrombosis. And although the homocysteine levels went down 20%, there was still no statistically significant difference in these patients. Okay, women are aware of their cardiovascular risk. This is my favorite study because I talk about it almost every day. In 2012, the American Heart Association came out with their big study that was performed over 15 years. And basically it was called the 15-Year Trends and Awareness of Heart Disease in Women. And approximately 2,500 women greater than the age of 25 years old were surveyed between the years of 1997 and 2012. Okay? What they were asked, basically, the number one question is, what are you afraid of dying of? What do you think your number one risk of death is? Okay? In 1997, 30% of the population said heart disease. That went up to 56% in 2012. So we knew from the Heart Association that we were doing something right and that physicians were doing something right in educating their patients that heart disease is their number one risk. The problem is that you'll notice in the minority groups, it really didn't change. So what that told us is we really have to get out in a grassroots effort and educate these women and have physicians educate your black patients and your Hispanic patients that heart disease is their number one killer. What you'll also realize is they asked what warning signs would you associate with having a heart attack, and that also increased significantly across the board in terms of what symptoms they thought that they would have. Okay, a very large NRMI registry between 1994 and 2006. There was 1 million men and women that were registered in this study. And this is a good study because almost half were actually women. So this is one of the first studies where we're actually represented appropriately. 42% of women that had heart attacks presented without chest pain versus 31% in men. There was a much higher in-hospital mortality in women of 14.6 than 10.3% in men. And younger women without chest pain were at much higher risk. What I can ask of you is if someone comes to the hospital and they're having pain from their belly button up, please do an EKG and troponins. And if something in your gut tells you it's not right, you have to repeat the EKG frequently, because you'll notice the T waves start to kind of flatten and you start kind of getting T wave inversions, and you're not going to see it unless you're getting the serial EKGs. Okay, myth number 6, men and women have the same risk factors for cardiovascular disease. There's a few things that are different among men and women in terms of risk factors. Obviously, the tried and true risk factors are the same, okay? Mom and dad and immediate family members, their cardiovascular history, smoking, diabetes, high cholesterol, high blood pressure, those are unchanged. But there's a few risk factors in women that are a little different than men. So what we do know when it comes to looking at a lipid profile, a low HDL in a woman is more predictive of heart disease than a high LDL. That does not mean we're not going to treat the high LDL, but we do know those women that have a low HDL have a higher risk of having heart disease than if their LDL is high. Are any of you familiar with the Lp(a) particle at all? Okay. So the Lp(a) is one of the most atherogenic particles in the body, okay? It's an LDL-like particle that is along with an apolipoprotein A that's bound to an ApoB. And if you ever see it on a board exam, B is bad. Okay, so the higher your apolipoprotein B, the more risk you have from a lipid standpoint. It's a very highly heritable issue. So if your mom has high Lp(a), the odds of you having it is also very high. The problem with this is that they're very difficult to treat. So you can throw 80 milligrams at Lipitor these people, and it will very mildly reduce their Lp(a). Diet and exercise barely change it. It is a very big risk factor because there's not much you can do to change it. So what I order these for is, one, I will bump up statin therapy because it does help a little bit, but it helps me to tell the patients that they need to be very diligent in keeping their weight down and doing everything else they need to do, because from a genetic standpoint, their odds of having cardiovascular disease is much higher, and there's not much I can do about it. And when you tell a patient there's not much I can do about it, they do usually everything they can to do something about it, okay? The other problem with the Lp(a) is it's similar to plasminogen and TPA. So it competes with plasminogen for a receptor site, okay? So you're having less fibrinolysis the higher your Lp(a). So it really does have it's very atherogenic. It's gonna compete, and you're gonna have a lot quicker buildup in the arteries than you would if you did not have high Lp(a) levels. So I order this test really for anyone. I usually order a one-time test anyone over the age of 40. And if it comes back elevated, then I'm very diligent about checking lipid profiles, and I'll recheck the Lp(a) almost every year. It is, I've had patients with an LDL of 80 and an Lp(a) through the roof, and I throw those people on statins because I know that their atherogenic profile is much worse than the person with a mildly elevated LDL and a normal Lp(a). Also, smoking's bad, but smoking in women is really bad, okay? Women who smoke have a 6 times higher increased risk of an MI. Men only have 3 times higher risk. Still really high, but we're double, all right? So the smoking in the women is, it's really, really, really bad. And that goes back to me telling you, if a woman under the age of 40 had a heart attack, 80% of them were smokers. It just destroys our endothelium. And I'm not sure why it destroys it worse than men. Maybe we're just more fragile. I don't know. But it does, okay? I want to share with you, and I said this on the radio yesterday, and I feel like sometimes when doctors just tell people not to smoke, it's bad for you, that doesn't kind of get through to people. And I want to share with you something that I tell patients that I found it kind of works. Let's take the cancer out of it, because the risk of cancer with smoking has nothing to do in terms of physiologic reasons as it does with arterial disease. So what I tell patients, they're like, well, what does smoking do? I don't understand. I said, you have a bowl of fruit, and you put saran wrap over that bowl. And the saran wrap keeps all the bad stuff out. It keeps the air out. It keeps it from getting moldy. It keeps all the bad stuff out. Am I correct? And they say, yes, you're correct. I said, okay. I said, your arteries have the similar lining. That lining is called your endothelium. I said, when you smoke, it's like taking a knife and punching holes in the saran wrap. I said, what happens? And they said, well, the air gets in and the fruit goes bad. That's what happens in your arteries. And that's how I get them to understand what's going on, because that is what happens. The endothelium's getting broken down. You're able to have more platelet aggregation, more cholesterol buildup, and that's what causes the premature heart disease. I like to share that because I found it kind of works. They don't miraculously stop smoking that day, but I feel like the more I can educate them and get them to understand what's going on in their body, the more likely they are to stop smoking. Heart disease is the #1 killer of American women. Do not take women's cardiovascular symptoms lightly. Please do me a favor. When you're doing a review of systems, don't graze over the chest pain part. What I tell my women, and it takes about 15 seconds to tell them this, and I know we try to get in and out of rooms. Your patients that are active, you need to tell your female patients, whatever you do day to day should not change. If you go play a round of tennis every day, you shouldn't be able to play a round of tennis on Sunday, and then Monday, all of a sudden you're very short of breath and you can't do it. That's your symptom, okay? Women present like that. They get almost this overwhelming sense of fatigue from one day to the next. So that's what I tell them. You should not, beyond having the flu or a cold or, something like that. But if you feel fine, and then all of a sudden one day you can't do today what you could do yesterday, that's a problem, okay? Again, menopause is not a prerequisite for heart disease in women. It is it's a gradual increase over time, so don't just think because someone is still having their menstrual cycle and they're having chest pain that they can't have cardiovascular disease. I'm going to tell you a story about that. It's a good story. Again, hormone replacement therapy has its place, but you have to be aware of the risks versus the benefits. So just to go back on that, if you're treating symptoms, you have to have the conversation with your patient, especially if they're more than 10 years outside of menopause, that it will increase their risk for heart disease and stroke. Its major place has to do with symptom management and early management within 10 years of menopause for a short period of time. You're going to get your biggest bang for your buck at your early surgical menopause patients, around the age of 35 to 45. Again, vitamins B and E do not necessarily decrease heart disease risk. There is that small subset of patients greater than 65 years old and women who may benefit from vitamin E. It's not a guideline recommendation, but that was shown in the study. Again, most women are still, only about half, are still not aware that cardiovascular disease is their #1 killer. But I spoke at a Go Red for Women breakfast, and it was people in the medical community and own businesses, very well-off, very smart people in the audience. And I said, I was trying to get them to understand something, and I said, if you're a woman in the audience and you know when the last time you had your mammogram is, raise your hand. How many people do you think raised their hands? All of them. All of them. I said, okay, put your hands down. And I said, if you know when the last time your doctor checked your cholesterol is, raise your hand. About half. Okay? This is, these aren't doctors, so give you some credit. And then I said, okay, keep your hands up. Those, let's say there's 40 people with their hands up. And I said, if you know the results of that, keep your hand up. They all dropped. But they all knew the result of their mammogram. The point is they still are so concerned about their breast, and I get it, I have them, I understand it. But they need to understand they're probably not going to die from that. They're going to die of cardiovascular disease. And it's our responsibility to inform them of that and keep them healthy, okay? And really drive home the obesity and the weight loss and how important it is to stay healthy. Okay? Because that's what's going to kill them. Like I said, I do primary care too, and I get 1,000 more phone calls about what was the result of my mammogram than I do what was my cholesterol. Okay? Again, women possess different risk factors for cardiovascular disease over men. Again, the Lp(a), having a low HDL is a bigger risk for women than it is for men, and smoking is severely detrimental to women's cardiovascular disease. I want to leave you with a story. I have a friend of mine who I met through the Heart Association, and you'll have to excuse me, she's got foul language, and I'm going to quote her. And she was 40, when she had her heart attack, she was like 43 years old, very heavy smoker, and she's a trip. She owns hospice companies, and she sold them, and she bought it back, and then she resold it. I mean, she's very wealthy and very smart. And they were in Boca Raton at a dinner with her parents who were in their late 80s, and they're a big Jewish family in Boca. And so she's homosexual. She's got a partner who we're all very close. And they get in the car to drive home from the dinner, and her name is Pam, my friend, and she turns to her partner, Sherry, and she says, I don't want to drive. Now, if you saw their car, Pam likes to drive. Okay, so Sherry goes, what do you mean you don't want to drive? She's like, I don't know, I don't feel good, I don't want to drive. And Sherry will tell you at that minute she knew something was wrong because Pam always drives. She says, I don't know, I don't really I'm having a little bit of chest pain. And then Sherry's like, look who we just went to dinner with, anyone would have chest pain. That was her response back. So they get about 3 minutes away from the restaurant, and they're within 3 minutes of Boca Raton Regional Hospital at the time. It's all on one big road in South Florida. And Pam turns to Sherry, I'm not going to use her words exactly, and she says, take me to the hospital, I'm having an effing heart attack. And Sherry says, you're what? She's like, take me now. They pull into Boca Regional, she walks into the ER, and she codes. In the ER. She wakes up, they get her back, she wakes up with an ambu bag on her face, and she pulls it off, and she said, did the heat win? That's all she cared about. She's got, I should show you, she's got floor seats next to the players of the Heat game. I went last week. And the ER doctor says, you woke up with an ambu bag. She's like, what happened? And he's like, yeah, you had a heart attack. She's like, I knew it. They took her up to the cath lab, 100% proximal LAD, okay? The other vessels were clean, because that's what we see in smokers. It's like one vessel. It's always like one vessel with the STEMI. 100% LAD, 42 years old smoker. You cannot take these people lightly, okay? You cannot. She has become the most annoying person to eat lunch with now, because when you go, she'll order, we go have an omelet in the morning, she'll say, yeah, I'll have the Greek omelet, egg whites, no butter, dry toast, no butter on the toast, don't make oil, no oil, dry. And I'm like, you can have a little bit of butter, it's not gonna kill you, Pam. So, she's really turned her life around, but what I tell my patients is I'd rather prevent a heart attack than treat one, any day. And we have to be very, very, very diligent. And I'm going to tell you from personal experience in treating these patients, statins, 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 statins. Because I have seen them regress coronary disease. I've seen it on a cath. Put them on statins. high dose, high potency statin therapy. Those new guidelines are legit. They're real. Okay? If you have a diabetic with another risk factor, they need to be on 40 milligrams of Lipitor. They do better. They don't die. Okay? If they can tolerate it, put them on it. Please. All right? That's the end of my presentation. I will take my own questions.
Could you please comment on arrhythmias in women? The PACs, PVCs, and when you would send someone for electrophysiology?
Okay, so did you guys hear her question about commenting on arrhythmias in women, particularly PACs, PVCs? I don't think there's probably a big difference in the amount of PACs or PVCs that they have. What I feel like is that women are more sensitive to noticing them, okay? So I don't think from an electrophysiologic standpoint they necessarily have more or less, but women, they feel them a lot more than the men do. So we have to treat them because they're annoyed by them, and we give them beta blockers, and that usually kind of takes care of that. From an AFib standpoint, it really has to do with age. So the older you are, the more likely you are to have the atrial arrhythmias. But I feel that in my practice, at least, I've noticed that women are just, they're much more sensitive to the perception of those extra systoles. Does that answer your question? Okay.
Yes. Can you please comment on birth control pills, smoking, and age?
Yeah. So I believe, and that's really kind of like an OB kind of topic too, but really after the age of 35, you really need to weigh the risks and benefits of being on birth control still, especially if the person's a smoker. I think if they're a non-smoker, you're probably okay, especially, still premenopausal. But in the smoking population, being on estrogen progesterone therapy is going to significantly increase the risk of blood clots. Mm-hmm.
Do you think a negative stress test in a female is less accurate than a negative stress test in a male?
No. I think you're talking to someone who's boarded in nuclear cardiology and doesn't even like doing nuclears. So from my experience, a positive exercise stress test should be taken very seriously, very seriously. Even a mildly abnormal exercise stress test. But I don't necessarily think there's a difference among genders in terms of a negative stress test being predictive or not. You really, again, this has to kind of do with your gut feeling as a doctor. If you really think someone's got coronary disease and you do a plain stress test or even a nuclear and it's normal, you have to step it up and order something else. And what I started ordering are cardiac angiographies, cardiac CTs. That's kind of been my test of choice as of recently because it gives me the information I need without having to do an invasive procedure. Mm-hmm.
Could you comment on hydrophilic statins, just as like Livalo, or I don't know if you're using them. What do you think?
Like
of them?
I'm sorry, you say
Livalo?
Oh, Livalo, yeah. I use them when I can't use the other ones for symptoms. Like if they have muscle aches, muscle fatigue on the Lipitor, the Crestor, then I go to like the Livalo, and they have much less symptoms. I'd rather something than nothing. But they're definitely not as potent. I mean, if you're going to pick your bang for your buck, they need to be on Crestor. I mean, that's hands down the most potent, followed by Lipitor. But I see some patients on like 10 milligrams of Zocor. I'm like, you might as well just drink a glass of water because it's not doing anything. So. Mm-hmm.
What is your opinion of the use of statins with over the age of 70? Because your emphasis is on prevention and, of course, those at high risk in their 40s. And I agree, treat those patients with statins. But what I've seen, when I take people off statins who are 80 years old, they walk better. And I'm giving them less medicines that they don't need.
I don't disagree with you. I think, especially around the age of 75, 80, I have the quality of life lecture with my patients. And I have taken them off things, and I said, listen, do you want to be miserable and not have a heart attack and live an extra 3 years, or would you rather like not be on all this stuff and feel better? And what do they say? I'd rather not be on all this stuff and feel better. So there comes a point where I have to have that quality of life discussion with these patients, and I don't necessarily disagree with you. I mean, I'm not trying to prevent a heart attack in an 80-year-old. I'm trying to prevent it in a 60-year-old, right? So I'd say if they're doing well on it and they feel fine on it, that's a different story. But if we think that, they're not walking as well and they're kind of having some muscle aches and, their kidney function's borderline, liver function's borderline, then I would probably take them off of it or at a minimum, decrease the dose.
Along that line, would you recommend for the younger woman who's on, let's say 10 milligrams of Crestor that has reduced the Crestor, that reduced, of course, the cholesterol below 200, and the HDLs are good and the LDLs are good. Would you push it to 20? Because you said statins and high-dose statins.
Yeah, when we talk about the new ASCVD risk factors, I do go on that. I really do, because we have to remember, we're really not looking at the number anymore. We're looking at percentage of decrease, or not even that, just more like we know that if you're very high risk and your ASCVD calculated risk is, more than 20%, being on that higher potency statin is really what's going to help prevent it. I got to tell you, I'm annoying to my patients. I push statins. I really do. And I'm not going to, I'd rather something than nothing. So if they say, well, doctor, I don't want 20, I'm only going to take 10, take the 10. I mean, I'm not, but I really try and push them because I've seen it. We do ultrasounds in my office. I have seen carotid intimal media thickness go down on high potency statins. I've seen it. So, if it's doing it in the carotids, what are the odds it's not happening in the coronaries?
Hi. I have two questions. First, I'm still not clear about the use of estrogens in women who have menopause before 60. And the second question is, if you look at all of these symptoms that women can get that men don't, they include things like anxiety, epigastric pain. Do you have any pearls in terms of how you would segregate people who you would think really do have cardiovascular risk or not? It's clearly not practical to evaluate every woman who could potentially have risk symptoms for cardiovascular pain as a cardiovascular patient.
Yeah, let me start with the first one, then I'll pop over to that. Really, when we're looking at sheer guidelines for estrogen or hormone replacement therapy, they really need to be having postmenopausal symptoms. If they're not having any postmenopausal symptoms, they should not be being treated. That's easy, right? If they are having symptoms, they need to be within 10 years of the menopause time frame. Okay, so if they had menopause at 45 years old and they're 60, we should not be treating those patients with hormone replacement therapy. Now, your other question's tough. And I guess for me, it's just, these patients, these are the ones that you really have to take time with. Because when you start talking to them and they say, well, I switched jobs and my boyfriend left me and I moved from Jersey to South Florida. I had one yesterday. I moved from Jersey to South Florida. And you start listening, and their symptoms really could be secondary to true generalized anxiety or true depression. And they're not having, they go for a jog and they don't have chest pain. The odds of that being cardiac are low. And I am one of the only cardiologists in the area that treat anxiety because they keep talking to their primary care doctor about palpitations, but they never get treated for it. And I put 50% of the women that come to my office with palpitations that I've ruled out true palpitations, they go on Paxil, 50% of them, and they're gone. Their palpitations, they're gone within 3 weeks of being on the Paxil because they've got generalized anxiety. You kind of have to look at family history and risk factors and true history on their chest pain. And I always, again, I go back to, do you exercise? If you do exercise, can you still exercise like you were able to exercise? And really try and pull it out of them. And in all honesty, if you're still unclear, just get a plain exercise stress test. It costs like $50 and it'll help put them into a different kind of risk category. Mm-hmm.
Yeah, I have two questions. I was trying to get Dr. Jacoby, but we can ask you as well. In terms of the calcium scores, can you just go over the calcium scores on the CT? When they first came out, several years ago, of course, I had one. It was the thing to do. They were offering it for physicians for free, and now it is very inexpensive to get. So when do you worry? What's, used to be 0's great, up to 10's okay. And then second fold is when you're measuring cholesterol and the LDL and HDL, do you use the NMR profile to look at the actual size of the molecules? I know that I kind of use that, especially if I think that the patient has some risk factors, but everything else is okay.
Okay. I do use the lipid cascades. I use them more to help me gauge my treatment, more so than starting treatment. I will tell you, I routinely order the LP(a), which usually is on those profiles. There's also a test known as the LPPLA2, which is a plaque test. That is an inflammatory marker that is present in patients with coronary disease or early coronary disease. The PLA2, the LPPLA2 will be elevated in those patients. So I do. And what I use those for is really, again, to gauge treatment. So if I have a patient with a normal LDL, and again, you're talking to a cardiologist, right? So if I have a patient with a normal LDL and an LPPLA2 of 250, where less than 200 is the cutoff, they go on statins because I know there's inflammation in those arteries. I know there is. So I do. I mean, but I think you'd be hard pressed to find a lot of people that use those panels because the studies on them are kind of wishy-washy. But I use it to help push statins because then I can say, look, there's inflammation in the artery, and then I can kind of convince patients to do what I kind of want them to do and twist their arm. I do not order calcium tests, coronary artery calcium. Although this is being recorded, I actually do go against guidelines on this. If I'm going to stick someone in a CAT scan machine, give them contrast and get a CTA. I mean, then you know what the arteries look like. So, and it's the same time in the machine. And the cost difference is like $200. So, I mean, you're talking about basically having a cardiac cath without having a cardiac cath. So the majority of my patients, if I'm pretty clear that they have coronary disease, they have a positive stress test, or like this gentleman was saying, I just, I don't know, but something inside of me is telling me that, something's going on, and they had a normal stress test, I get a cardiac CTA. I don't even bother with calcium scores. Here's the problem with calcium. It's calcium. The people that have ruptured plaques, that's not calcium. They've got a thin fibrous cap, and they rupture. Those patients have STEMIs. You can have a calcium score of 1,000, but it's rock-hard calcium. That thing's not going to rupture. So it doesn't really help you. I mean, it tells you that, yeah, the arteries are starting to calcify, so your potential for having an adverse event in the future is higher. But your potential of having an adverse effect tomorrow, it's not going to change it. So I just get the cardiac CTAs. And in my hometown, I can get a cardiac CTA, contrast done, red, package price, $500. It's like having a cardiac cath for $500. I mean, you can't beat it. So, does that answer your question? Anything else?
What do you think about cardiac PET scan?
They're awesome if you can get them. You're talking like for like a nuclear PET for ischemia. I love them. Have you seen them? They're beautiful. The pictures are unbelievable, and they're extraordinarily accurate. The problem is they can't exercise, so you're having to give medications, and so you have that aspect of the test taken away where you're looking at someone exercise and you're looking at how they look and if they're really able to exercise. That's an invaluable part of a stress test. I had a little Cuban guy who was like the nicest guy in the world, and he told my husband, who's his primary, that he was having chest pain when he had intercourse. If you ever hear that, they've got coronary disease, okay? Because no man ever wants to complain about something during sex. So if they come to you and say, I've got chest pain when I have sex, it's real, okay? So I put him on the treadmill, and he walks no more than 2 minutes, and I'm looking at him, and you have to look at the patient. Sometimes you don't look at the EKG, you look at the patient. And I'm looking at him, and he's having difficulty at 2 minutes on a Bruce protocol. He should be kicking it. And he's like, I'm fine, doc, I'm fine. And I glance at his EKG, and it was the most horrendous stress test I've ever seen, ever. When you see a positive, there's something to be said about watching someone exercise. It's an invaluable test, because when it's positive, it's positive. I get this guy off the treadmill, he almost passes out, starts grabbing his chest, goes to the hospital, 4-vessel bypass the next day. I mean, it was unbelievable. I really like to exercise people if I can. If they can exercise, I like them on the treadmill because people lie to themselves. Oh, I walk. No, you don't. I put you on the treadmill for 30 seconds and you're out of breath. They lie. And then when you put them on the treadmill, they realize very quickly that they can't exercise like they used to. So I love PET. If I had to choose between, a LexiScan nuclear and a PET, it'd be a PET all day long. But getting them approved is difficult, and finding the diagnostic centers that can do them sometimes can be difficult, but it's a beautiful test. Beautiful. Anything else? One more. We have time? One more.
What do you think about the suggestions that radiologists should look at coronary calcium in
Oh, I think that's a big gray area. I don't, you know, I had a patient come to me. My mammogram was normal, but they said they saw calcium in my arteries. Now what do I do? I mean, it's like, now what? Now you have a piece of information, so now it's got to be worked up, right? So now I put them on the stress test. I mean, now you're forced to work it up because now, I mean, legally, someone has told you that there might be, you know, calcified coronary disease. I mean, you can't leave that alone. So I don't blame anyone for doing anything to CYA, ever. I will never blame anyone for that. But now that someone comes to me with it, now you at a minimum have to work it up. So, you know, those patients get a normal workup like any other patient would. They get a lipid panel, and they probably get an exercise stress test, and the exercise stress test is low risk, end of story. Yeah, sure, one more.
What is the value of a chemical stress test? Do you get as much information?
No. Chemical stress tests should really be reserved for patients who need a chemical stress test. What happens, and I apologize to other cardiologists in the room, is that it is inefficient with time to do an exercise stress test. Because you get patients that walk on the treadmill for 20 minutes, and I'm very jokingly with my patients, I said, you need to hurry because I'm getting paid the same no matter how long you walk on the treadmill. And I just start bumping up the ramp because I get tired. The problem is that I'm like, next stage, I'm bored, next stage. The Lexi scans and the dobutamine, they should be reserved for patients who have a left bundle, a non-diagnostic EKG, and can't walk. That's it. They need to walk. Walking is hands down the best tool we have in cardiology. It's symptoms. It's symptom-driven, and patients lie. They tell you they can exercise. So if someone says, oh, my knee's a little bad, can you just give me the chemical? Modified Bruce. I mean, I make these people walk. If your knee's that bad, then I'll take you off the treadmill. But what I realize 9 times out of 10 is they can walk. They just don't want to. So I put them on the treadmill. And the information you get is invaluable. Because now, guess what? Now they really do need a study, and now I can get it approved. Because now I've proved that they have a positive stress test. So I think that Lexi scans are grossly overused. Because the doctor physically doesn't need to be there. I mean, you need to be within the same 4 walls, but like you don't need to be in the room. And I get it from a time standpoint, but you're doing your patients an injustice, especially women with large breasts, men with big bellies, and obese patients. It's useless. It's going to be a useless test because there's going to be artifact on the test.
One last comment, not really a question. I think the biggest driver in the difference between men and women with coronary disease is the diminutive nature of their bodies, their heart size, and their anatomy. It's all Bernoulli's principle.
Correct. Yeah, he was saying, you know, the difference with men and women and their heart disease is just their sheer anatomy and their heart size, right? Women are going to have, they've got smaller hearts, they've got smaller arteries. You know, it is what it is. So, you know, the cholesterol builds up in a smaller artery, you're going to have a problem a lot faster. But yeah, I mean, it's all physics.